My topic was not easy to address because it's an easy concept. We should all work together, and this is the fact. And the fiction in the title is that at the moment, indeed, we should all work in a team, but that's not the reality. Presentation is still uploading, I'm sorry. Oh, okay, good. And one important point is that it's not only vascular access. If we consider all the aspects of care of patients with chronic kidney disease, all of them require a team care approach. Management of CKD in the pre-dialysis setting. Kidney transplant is a typical access-based approach. You have surgeons, transplant surgeons, nephrologists, intensivists, nurses. And the choice of dialysis modality also needs a team approach. You need to see all the different aspects of dialysis. So you need to talk to the peritoneal dialysis nurse, to the hemodialysis nurse, and nutrition experts. And peritoneal dialysis access also needs a team approach, and of course, hemodialysis, and that's the reason why we are here. And this is just very shortly to summarize what should be the pathway to renal replacement therapy. This is a manuscript that we published in 2007, and the end-stage renal disease treatment algorithm, in our view, is the following. At stage 4, when GFR is reduced to less than 30 ml per minute, you need pre- and stage renal disease education so that, if possible, the patient will go to preemptive transplant. And if this is not possible, then you should prepare for dialysis with a first choice, still in our view, for PD, and as an alternative, when this is not possible, to hemodialysis. And then you can have an interchange between the two modalities. And of course, from here and here, you still can go to cadaver transplant. The concept of team-based care is not very old. It's, in my view, rather new. It's an approach, a patient-centered approach of the 21st century. And in fact, I think that the seminal papers in this field appear around the year 2000. And they come from this Institute for Healthcare Innovation from Seattle. And Edward Wagner is the main author of this and the leading person in this group. So in this publication of the British Medical Journal, they came up with a definition of patient care team. What is a patient care team? A patient care team is a group of diverse, this is my own way of highlighting the key words here, a group of diverse healthcare personnel who communicate, that's another key point, with each other regularly about the care of a defined group of patients and participate in that care. And these are two other additional publications from the JAMA from 2002, same group, and they came out with this definition of a chronic care model. So this team-based care is a foundation of chronic care model, which calls for productive interactions between informed patients. So this is a fourth keyword. The patient is a part of the team, and proactive practice team to improve health outcomes for persons with chronic medical conditions. And the key concepts still are the fact that delivery of healthcare by a coordinated team of individuals has always been assumed to be a good thing. Patients reap the benefits of more eyes and more ears, the insights of different bodies of knowledge, and a wider range of skills. And thus, team care has generally been embraced by most as a criterion for high-quality healthcare. But despite all of this, and the appeal that comes from this, team care remains, in 2000, a source of confusion and some skepticism. And I think that in 2015-16 is still this is still true. Two important questions when we think about team care is which disciplines are essential for the development of a team, and what do the team members do to support patient care? So I think that these are two very important questions that we should ask ourselves when we think how to organize patient care. So who does what, and which specialists and which healthcare personnel is essential for a good team care. Just to give you an example of a publication regarding team care in the kidney disease area. This is from 2011. And the title is very self-explaining. Multidisciplinary team care may slow the rate of decline in renal function. And of course, this is one of our main objectives. And key points of this publication is that usual care usually consists of referral to an outside nephrologist, but the multidisciplinary team care consisted of several different healthcare personnel, which was internal nephrologist, in this case an health maintenance organization-based nephrologist rather than outside nephrologist, pharmacy specialist, diabetes educator, dietitian, social worker, and nephrology nurse. So in this specific team, they decided that all these different figures were essential to the team. And so there are many of them. And it's interesting, we don't have this. Usually the pharmacist in Italy has a very marginal role in patient care, but in the US, they did include the pharmacist in the team. What was the primary outcome of this study? The decline of GFR, and here are the results. More than the figure, which is not very nice, I think the numbers are very important. When you have team care, you will have 1.2 ml per minute of decline in GFR. This is compared to the regular care, 2.5 ml per minute. That's a huge difference. So you reduce by 50% the progression of kidney disease. So let's go to access, vascular access team care. So based on what we saw, we should define the access center or the access team care by the team members and by the kind of organization that this access center will have. And ideally, we should have a continuum of care between the different specialists so that the patient is the center of the team care. So the people interested and that should be involved are the nephrologist, the interventional radiologist, the surgeon, and an access coordinator, which usually is a nurse, but can be also a different person. Also, a nephrologist can also be a surgeon. A surgeon can also be an interventional endovascular procedure specialist. So it's not the specific specialty which is important, but the fact that there are dedicated people to vascular access. And important points in the organization structure are a shared space, ideally, where they can work together and have a direct contact. The fact that the patient can have a so-called one-stop shop, so that the patients can see all the different specialists at the same time, and all of this should be patient-driven. So expanding the role of the team members, in addition to the patient, and so what we already saw, we have to introduce the dialysis unit, because it's not only the creation of the access which is important, but also, as you know, maintenance. So the role of all the people, nurses and doctors working in the dialysis unit is very important. And also, administration can be important for the decision that they can take in dedicating resources and spaces to vascular access. And also, we can have technologists which are now developing in many countries, and they are taking care of imaging, and especially of duplex Doppler and other technologies in the interventional radiology suites. So an example of team approach, I want to praise the organizers of this meeting and also to thank them for the invitation, Jose and Ramon. They are team builders, so they know how to do that. And this is just from the program, an example. They were able to gain the support of many different scientific society, and this is actually what I think is at the core of a vascular access team, is who is trying to get together the people. So why do we know the team concept? We need this because team working facilitates solution to problems. It is convenient for the patient. We learn from each other. I think this is one of the most important things. It is convenience for the perspective of a national health system, because you will have savings by having less catheters, for example, less infections. And even in private practice, as it is happening in the US, it is convenient for business, because a very well-organized access centers will attract more patients. So how do the team members have to deal with the construction, maintenance of vascular access? In these slides, which I modified from a slide by Ingmar Davidson, we have a working access which should be monitored, and we have two possible bad outcomes, which is clotting and malfunction. So if we have clotting, we should go either to radiology for a PTA or to surgery directly for declot, and with the possibility and the need to introduce a catheter. From PTA, if we fail, we go back to surgery, and if we succeed, the access will be working again. And if PTA fails, we will need a catheter and then go back to surgery. And malfunction also needs to evaluation with duplex Doppler, and if needed, interventional radiology, PTA, surgery, you see, and then we can go back to a working access. So this summarizes the concept of the access team. The patient is at the center. You have the different specialists and the dialysis unit as well, and the very important figure of the access coordinators, which bring everybody together. So in conclusion, individual medicine currently implies a patient-centered approach, and we have now the news from the United States that they will invest in the coming years a lot of money in what the so-called precision medicine. On the other hand, while we go on the individual, we also, in my view, need to go on the team. Providers should work as a team in most circumstances. And doctors who do not work in cooperation with other healthcare personnel are more likely to provide low quality care. So the fact is that the efficacy of a dialysis access team is certainly higher, but the diffusion and acceptance of dialysis access team in hospital with relevant dialysis centers is still fiction, and we should work and trying to fix this. Thank you for your attention.